nephrologist or their GP or their internist refers the patient and picks up, something going on in the urine. And one of the most prominent things that we look for is protein in the urine when the kidneys become leaky. Right? The filtration is not working as it should. And they leak protein instead of reabsorbing that protein. We want the protein to be reabsorbed from our body. But it leaks, and one of the earliest signs, sometimes, as I said, it could be just a raise in your blood pressure from its baseline, or the patient presents with swelling, or they notice that the urine is quite frothy, or they may notice that the urine output, how much they pass, is less. They may also, they may not even have signs and symptoms related to the urinary symptoms. They may just have general symptoms of fatigue, not feeling their usual state of health. They may feel they're not sleeping well at night. And again, a lot of these symptoms overlap with just, having lupus. But again, a lot of these symptoms, a lot of kidney presentation of kidney disease is generalized symptoms. So they may be asymptomatic, or they may present as a full lupus kidney flare where they become what we call nephrotic. Generalized swelling, short of breath, and accumulation of fluid within the lungs, within the legs, within the abdomen, within the back. They may present with heart failure. So there's a spectrum of how the patient with lupus can present. But the most important thing is that they may not have symptoms, and their primary physician should screen them once yearly with a basic urine test.
So that's really a huge take-home message, is that you may not have symptoms early on of kidney disease, and so you really have to check. And what you're saying is that one of the most sensitive ways to do that is to check for protein in the urine. Do you ever have patients check their own urine for protein?
We actually encourage patients to do that. And I've done that in my clinic as well, where we've had pregnant patients who started to flare pregnancy. And we gave them a bottle of the urine dipstick strips, and they were educated by the nurse on how to check and to record their protein, blood, leukocytes. So we educate them. And so absolutely, what we want to do, Dr. Tullery, is empower our patients to have them engaged in their healthcare so that they can make better decisions with their healthcare provider, so that we can have an overall positive outcome. And the earlier, the better, because kidney disease can become progressive in the lupus patient, and progression can lead to something called going on the machine called dialysis.
Okay, and so wow, so I mean, we even have a question about that, but if you don't mind expanding a little bit, because everybody kind of wonders if their kidneys are involved, is that what are the possible consequences? Everybody wonders, am I going to be on dialysis? Or maybe some people, so can you expand a little bit about the range of ways that the kidneys can affect you? What's your prognosis if you find out your kidneys are involved? Right. And how do you know what your prognosis is?
Now, many times we can't assume that a patient with lupus has what we call lupus nephritis. A lupus patient can have a myriad of any of the primary kidney diseases that are out there. So one of the distinguishing things that we do, if a patient starts having manifestations in terms of their blood tests showing their creatinine and their bone is becoming higher, they're spilling protein in the urine, they have generalized symptoms, raised blood pressure, we want to find out, is this related to a lupus flare, or this could be a non-lupus involved. So remember, the lupus patient can have other kidney or renal manifestations of other kidney diseases that can mimic lupus. They can have what we call a vasculitis, which is inflammation of the blood vessels. And that's just the nature of possibly that patient's genetic makeup, where they have a lupus kidney, or they may not have a lupus kidney. kidney disease manifesting as something else.
So basically, a lupus patient can get kidney problems for the same reason everybody else gets kidney problems.
Simply said, perfect, yes.
But then again, the lupus itself. So this actually segues into one of the questions that we have. The question is it the kidneys? Is it the drugs that people take? Is that a question from Simone? I want to know, is it the condition that affects the kidneys, or are the hard drugs and long-term medication one has to take? So what is really causing the kidneys to be affected? Is it the kidney, is it the lupus, or is it your meds?
It's a multitude of things, as we call it. It could be multifactorial. Again, the lupus itself is a disease that has a lot of questions still unanswered. We don't even know what causes it. They say environmental, viral, genetic, and that is what makes lupus so difficult, to manage in some of these patients. And it's kind of similar to renal disease or kidney disease. So a patient with lupus who manifests with some kind of kidney impairment, we have to do a little bit of detective work to find out, is this related to the medications? So yes, long-term use of certain medications such as steroids or some of the immunosuppressives that we use are what we call nephrotoxic or toxic to the kidney. But there's ways of us managing that with the patient with regular blood tests, urine tests, and checks. Again, if the patient had an acute intercurrent illness, that can affect the kidney as well. So it's a multitude. We can't pin it on one thing.
So would it be safe to say that most of the time, what we're really focusing on today is how lupus affects the kidney? I don't know, in your experience, because you deal with kidney issues from all kinds of causes. I know for me as a lupus doctor, the most important thing I want to find out is whether this is lupus kidney disease. And in my experience, 95% of the time, it's the lupus. I mean, I don't know if that's, really, but most of the time. What are some of the medications that really, in reality, could affect the kidneys in lupus patients?
Well, again, as I said, some of the immunosuppressives that they use, tacrolimus, which is a calcium urine inhibitor that we use, that is known to be nephrotoxic, and we have to keep that drug within range. I'm going to start with.
So that's not really a very commonly used drug, right? That's actually quite rarely used.
Right.
And we actually use that in people who have severe kidney involvement most of the time.
Right.
Yeah. So it's actually being used to prevent the lupus from damaging the kidneys. But you have to keep it
or for flares. Prednisone, mycophenolate, or you guys call it Cellcept. These medications can all have effects on the kidney, but it is used in a way that is therapeutic for the patient, and so we have to monitor the patient in that regard.
Okay, so I find that I'm a little bit surprised at that because of the fact that mycophenolate is one of the main medications we use. So should patients be afraid to take it because of the kidneys? I mean,
no.
Okay, all right. Because I'm thinking most of the time it's the opposite. Okay, so mycophenolate is one of the drugs that we actually work hard to get subsidized because it's one of the safest drugs that we have that we can use to save people's kidneys and keep them off dialysis. So we're just trying to create some balance there.
That's right.
There's one category of drugs though that we always tell the patients to avoid if they have kidney involvement, and those would be the certain painkillers that we call the Nsaids or non-steroidal anti-inflammatory drugs.
Now that is a balance because it's a very good drug for pain and inflammatory arthritic disease. However, depending on the stage of the patient's kidney disease, it can worsen and cause significant injury and acute kidney injury and even long-term effects. So there is a balance with using these drugs, especially in patients who have more advanced kidney disease, stage
All right.
4 and 5. So those drugs, we're not saying that it cannot be used, none at all, but they may have to be used in shorter courses at a monitored, in a monitored situation.
Okay, so we've answered quite a few of the questions and we're running out of time. We actually answered about the early signs. What is the early signs that lupus is affecting kidney? And you talked about that, across the urine, protein in the urine, and raising your blood pressure. The signs and symptoms to look for, so that's the same question. And we asked, we have a question about a specific symptom. Before I ask that question, I wonder if we can expand a little bit in just a minute or two about the kinds of medications. The question is, what medications are introduced at the early stages to combat the disease? And by that, I'm thinking that this is before your kidneys are destroyed or severely damaged. So that would be the early stages. What medications do we use? Do they work? And what are the long-term side effects?
So in terms of introducing medications at an early stage, I'm assuming that the patient has kidney involvement. One of the mainstay drugs that we use are called angiotensin converting enzyme inhibitors or angiotensin receptor blockers. And these medications have dual purpose in terms of kidney protective effect. It helps to lower blood pressure and it also helps, it's an anti-proteinuric effect, helps to decrease the amount of protein that is leaking out of the kidney. And it's one of the mainstay drugs that we try to start to use very early and try to maximize the dose at the highest possible tolerated dose for the patient because it is a kidney protective medication. That is one of the mainstay drugs that are used in these patients.
All right. And what about the drugs that actually change the course of the disease and prevent the lupus from destroying? Because that can happen, right? So we talked about different types of ways that the kid, some forms of kidney involvement are worse than others, but there are forms that can actually rapidly destroy the kidneys. So in a few months, you could be on dialysis. I've seen that happen in children. So what are the drugs that would actually stop that process from occurring and preserve the kidney?
In terms of if the patient, I'm not understanding this.
In terms of actual disease that actually stop the kidney, the lupus kidney disease from damaging the kidney. So the question is, what is introduced to combat the kidney disease?
Well, besides our mainstay of, because sometimes by the time the nephrologist sees the patient, they would have been on treatment from the rheumatologist. And so when we get these patients, we inherit them already on low-dose prednisone, Celcept, myphenolate mofetil, stomach protections for that, vitamin D for bone protection, and of course, any other medication if they have any other comorbid conditions. So diabetic medications, insulin, and of course blood pressure medications if they have heart failure. So we would inherit them with those. There are some patients that we as nephrologists actually diagnose with lupus because they present swollen, they are young, middle age, or reproductive age group, and we do a biopsy on them. So we do a biopsy and we can see that the biopsy shows active and chronic lesions of lupus in the kidney. And so in those instances, if they're flaring, then we'd start them on some heavy immunosuppressives.
Okay. So you actually have to, you actually need to suppress the immune system that's attacking the kidneys to prevent it from destroying the kidneys, especially certain types of kidney involvement. So how important is a biopsy? Can you tell us more about the biopsy And do patients all need to get a biopsy if their kidneys seem to be involved?
Right.
What does it tell you?
Right. So not all patients need biopsies. We use biopsy as both a diagnostic and prognostic factor. So those patients who present brand new and presenting with signs and symptoms, we will biopsy those patients, and it can tell us exactly if lupus is affecting the kidney. And the pathologist can actually stage it to see if there's active or chronic lesions in the kidney, or if they see anything else, because sometimes the pathologist also sees changes of blood pressure, the end effects of blood pressure in the kidney biopsy. There are patients who are long-term lupus patients who've had lupus for many years, doing well, in remission, and then they have a little blip. Their kidney function starts to go off, it gets elevated, they're feeling a bit sluggish, a little bit of swelling. So those patients, we also want to biopsy those patients to see if these are active, new lesions going on, or the patient has progressed. But there's different classes of lupus nephritis or kidney.
So the treatment may vary depending on what you find on that biopsy. So it can be very important.
Very important.
Can you explain what a biopsy is and maybe how it's done?
So a biopsy is a procedure where the doctor basically pinches off a little piece of kidney tissue. It is a same-day procedure. Actually, we can do it at the bedside or in a procedure room. Unless it's a child, of course, it has to be done in theater under general anesthesia because it wouldn't sit still for it. So what we do, we consent the patient, let them know all the pros and the cons of what we're doing, book the patient. It's a same-day procedure, so the patient would present early in the morning to the hospital. We reserve a bed because it requires a 6 to 8 hour post-biopsy bed rest. Once we make sure that the patient is optimized for the biopsy, meaning that the blood pressures are well controlled. When well controlled, I mean systolics very low, less than 140. Their sugars are controlled. They have no urine infection or any other infection, and they pinch off a piece of the kidney.
Good. All right. So that's so it sounds like, as you said, same day procedure. You might be slightly sedated, but you're awake, and you just have to be observed a bit afterwards. It's done with a needle, and they take a little piece. And of course, the pathologist interprets it because they analyze the kidney.
Right. And I'm very happy to announce that we do have a renal pathologist, kidney pathologist specialized in kidney diseases, so that when we do our biopsy, it can be read by a specialist.
One of the best, one of the best anywhere. Really excellent. And we're happy that Lupus Foundation was able to contribute to this process recently. Yes, about a year and a half ago, we were able to donate to microscopes for the renal pathology unit. So because of this, how important this is. And, the doctor there has been training other pathologists to interpret kidney involvement. So we're out of time, but we just have 2 questions that I must press to get in because they're very specific questions and I know people will be looking for the answer. So I'm showing you this one in the chat. It's from a member who says, I occasionally get a lower back pain that feels like a kidney infection. Occasionally it's called me to go to the ER, but they never find an infection. It carries on for a few days. I increase fluid intake and flush my kidneys and all responds to normal. Do the kidneys get inflamed by lupus like other parts of the body, or is it something I should be more concerned about?
Well, back pain in any patient that's persistent is a cause for concern. And yes, although the kidneys are located in the back, it could be other organs or referred pain from, especially from a woman's pelvic organ. So she really should be checked properly. Cultures should be done, checking for the urine, and having possibly some type of imaging done to ensure that it's not something sinister.
Or like stones.
Or right, exactly. So we won't know until the patient is properly investigated.
Okay,
So
all
I
right.
hope that answers. I'm so
So
sorry that we're out
it's
of time.
appropriate to go, if
Sorry?
it's persisting, it's appropriate to get it checked out.
Absolutely.
Yeah, or maybe she could check her urine like some of the patients that you have. Here's another question. This is I guess it's more general, but I maybe come back to this one. It has to do with kidney involvement, osteonecrosis of both hips due to taking prednisone, and you get replacements. How well did you get back to how you were? I'll just quickly mention that Dr. Lowe-Jones did mention that, having to take prednisone to shut down kidney inflammation if the kidneys are at risk can sometimes lead to complications. One of those are bone complications that she mentioned. The osteonecrosis of the hips, it's something that can happen in lupus patients. And if you suddenly get pain that you're not in the hips, in the groin area, or difficulty walking, you should get that checked out right away, because sometimes the process can be stopped from getting to the point where it damages your hips. And the rest of the question we may need to actually have a special session about the musculoskeletal bone health with lupus. And here's a question two questions, okay? And one is, I'm not financially stable, but I need to be on dialysis. How could that be scheduled for my assistance? So can you expand a little bit about if a person needs to be on dialysis?
Okay. Well, hopefully the patient attends one of our nephrology clinics in the public system. It's quite a dilemma currently because many of the public systems are quite overburdened in terms of staffing and not enough dialysis machines. And so henceforth, the kidney disease keeps coming, not just from lupus, but from all spheres. And we don't have the capacity to dialyze everyone in the public system. So unfortunately, those patients would have to be spilled over into private. Financial constraints is a huge issue in access to renal replacement therapy in Jamaica. And it's one of those things that we all have to, through government partnership, public-private partnerships, to try and increase the access. Currently, there is a Chase Fund, and the Ministry of Health has an application form to assist those with private dialysis, although it is for a finite period.
Okay.
Yeah.
Okay, so that's helpful. And some people may be wondering what dialysis is.
Dialysis is basically a machine that does all the functions of your kidney in terms of the filtration, the toxin clearance. That you go on 3 times per week optimally, where you stick on the machine for about 3 to 4 hours, hook yourself up through a catheter or a fistula, which is some kind of access on your body, and you're attached to a machine for 3 to 4 hours, which cleanses your blood, removes some of the excess fluid, and then we do it again 2 to 3 times per week.
So
for the rest of life, unless we get a donor for that patient to get a kidney transplant.
Okay, so that's the blood dialysis, which is the most popular type. And of course, some people may know about the dialysis you do through your abdomen, which is we call it peritoneal. But the blood dialysis, they go directly to your blood and they filter it there. So that's some good pointers. If you have financial constraints, I know I work at Kingston Public Hospital, and sometimes you do have to wait a little, sometimes a couple of years maybe, to actually get on the dialysis that there's no fee for. And in between, many of our patients do have to apply for systems to get private dialysis until their name comes up. But of course, they have to get on, try to get on the list early. And also to try to anticipate early when dialysis may be needed. So the earlier you can get on these waiting lists, the better for you, right? So here's a question. Is there anything we can do to prevent kidneys from being affected?
Well, one of the main things is to try and stick to your medications. Keep your blood pressure if you have your hypertensive patient. Keep your blood pressure below 130/80. Have good control of your diabetes if you're a diabetic patient. Um, Keep a healthy lifestyle in terms of exercise, a well-balanced diet, adequate hydration, and of course, most importantly, a positive mental outlook. Because if the mind is not there, then the body will suffer. Good psychosocial support from family and friends. Hopefully, the persons are involved in a productive um, way of life to, working or employed, if not to volunteerism. So don't stay at home, get out there and just be a
Yes.
rounded person.
So important because there's also a question about whether menopause affects the kidney and also if there are certain foods that one cannot eat.
Again, it depends in terms of the foods. It depends on the stage of the kidney disease. If it's very mild, then they would have the same food restrictions as a healthy person. Keeping your salt low, keeping your cholesterol or the fatty foods low in your diet, increasing your fiber, nuts, grains, bran, unless if you're a patient who is more advanced in your kidney disease, there are more stringent restrictions such as keeping the phosphorus low in the blood in your body, keeping the potassium low. Again, salt is a very large driver of water retention and elevation of blood pressure. So it depends.
So if you're at the late stage and your kidneys are really not functioning properly in that filtration mode, then you can't have all that potassium and
Right.
phosphorus.
Our beloved coconut water would have to be.
And you certainly can't have a lot of salt.
Definitely not.
And some people can't have much fluid either because
That's
if they're
right.
really at the late stage where they're not even producing the urine,
That's right.
they have to restrict their fluids, which is not
That's
easy.
right.
So we have hope. What do you say
Yeah.
is the outlook? Are these better days for kidney involvement? Are there better days ahead?
Uh, from my view, it doesn't look very getting any better because the kidney involvement is quite pervasive. And what I find is that it's attacking persons even younger. So before, the patient would have lupus and they would manifest their kidney disease until, a few years on with the disease. We're finding patients present full stop in the beginning,
Yes.
20-year-old with kidney disease and quite
Yes.
advanced kidney disease. And that's very frightening because you're looking at a population that is, a lot of them is going towards end stage kidney disease quite early.
Yes, that's a tough situation.
Yeah, so
That's a tough situation. And I want to say, from the rheumatologist standpoint, that exactly what Dr. Lowe-Jones said, that a lot of the time when it comes to lupus affecting your kidney, we know that other things can affect your kidney, but lupus affecting your kidney is no respecter of persons. And in fact, the persons in the younger age group are more commonly have kidney involvement. So children, teenagers, 20-year-olds, 25-year-olds, those actually more commonly get kidney involvement, even than the ones who develop lupus when they're 30, 40, and so on. So the kidney involvement can come on quite suddenly, and so we have to be very vigilant. And when we see signs of it, we have to act quickly. So there can't be a lot of hesitancy, not wanting to do your biopsy, not wanting to take the tablets, and so on. Time equals tissue, and kidney tissue, it can be very precious. And at that age group, we do have some young people with very aggressive. So the lupus just starts to attack the kidney for no reason. And so you have to shut down that inflammation. And I think the range of drugs that we have available, certainly in my time, has really improved, and our access to them has really improved. So if we can get more people to be knowledgeable, to look out for signs, to ask about their urine being checked and ask their doctor and so on, diagnose it early if it comes on, and just jump in and do what you need to do to shut down that inflammation and just preserve the kidney. So that's what I'd like, just my 2 cents. So, and if we get the kidneys, very often you can get the kidney inflammation remission. That's great, you know, and you can get off steroids and that kind of thing. So more and more that's becoming a possibility. So we want to keep people hopeful that they do have a window of time when you can really jump on top of your kidney involvement and really try to preserve that precious kidney. But if you do find that you need support, then we know that there are ways to do that. Dialysis is available, and the transplant program has started again. We're hopeful that you know, that will continue and expand. And so we really just want to thank you all the time. We have to have part 2, or we have to have multiple episodes. We have to do this every year or every 6 months, lupus and the kidney. But we're really so grateful. Thank you so much, Dr. Lowe-Jones, for joining us. Do you have any parting words you want to share with your fan base? Because we remember you from the symposium. Everybody loved your presentation, and we're so happy to have you again. So
I want to say that this is a great series, and one thing I admire with the Lupus Foundation of Jamaica is it's a grassroots, volunteer-led member organization by many of them patients, and that is the foundation of a strong organization to help spread the knowledge and the importance of the disease, because a lot of persons are walking around the disease don't know. So I wanted to say congratulations on that front and for your leadership in terms of keeping the presence in the media for lupus patients, and and of course, again, very importantly, their whole well-being. So remember, the patient is not just the kidney, it's not just the heart, it's their entire well-being. And we have to remember that we want to empower our patients to make decisive and informed decisions about their care in conjunction with their healthcare provider. So it's not do as the doctor say. I want to make sure that everybody gets at least a screening of their kidneys once per year with just a simple urine test, urine dipstick, or quantification of their
every visit,
their protein,
right?
And try to be healthy overall, right? So it's a overall health that we're trying to achieve, and hopefully the kidneys will remain healthy on that front as well. But I want to thank you all and the listeners, and if any other further questions, I'm available.
Wonderful. Dr. Lowe-Jones remains a volunteer with the Lupus Foundation, so we look forward to having her continue to be accessible to you. Thanks so much, Dr. Lowe-Jones, consultant nephrologist at the Mandeville Regional Hospital, and our resource person here at Lupus Foundation. Thank you so much for sharing that information with us. We want to thank Racquel Thomas. She likes to be behind the scenes, but we're calling her out today. Racquel Thomas, for really bringing this whole thing to fore, helping us launch this wonderful series, and coming on month after month to help us, bring it to you, promote it on the social media, stream it, so it's available for you. You'll be able to watch this on Facebook, and you'll be able to watch it on YouTube. So don't forget to like our page, and don't forget on our YouTube page to go there and subscribe to the YouTube page and select the bell. That gives you, somebody's going to help me with this, the alert, the notification bell, so that you will know when new content is loaded on, you'll get notified. So stay connected with us, become a member. If you're not a member, volunteer, get involved, just get in touch with us. All our information is on the site that you're watching right now, and we look forward to having you join the fight. We're all part of it, getting the word out there and supporting each other. So thank you so much. See you back on the first Wednesday of every month, 6 p.m. for another episode of Ask the Expert Live.
Thank you.
Bye.
Bye-bye.